So with that, I'm going to thank Dr. Bender Ignacio, and we're going to go ahead and transition to our first panel discussion. I'm going to introduce the moderator and then have him introduce the panelists. So the first panel discussion is focused on typical cases in prevention and outpatient care for COVID-19, still the bulk of what we do in terms of treating COVID-19. And this has been going to be led by Dr. Arthur Kim. I can really think of no one better than Dr. Kim to lead this discussion. Dr. Kim is the director of the Viral Hepatitis Clinic and the Division of Infectious Diseases at Massachusetts General Hospital. He has really been at the forefront of care of people with viral hepatitis for many, many years, has had a prominent role on the guidelines for hepatitis C treatment. In addition to his role in viral hepatitis, he's on the Department of Health and Human Services HIV guidelines panel and the NIH guidelines for COVID-19. And in that role, he's been one of the leaders. He's also the medical director for COVID-19 here at Massachusetts General. So I'm going to turn the microphone over to Dr. Kim and have him introduce the panel and lead us through a number of cases. Please keep the questions coming in the Q&A, and again, we'll get to as many as we can, and certainly in the roundtable. Over to you, Dr. Kim.
Thank you, Raj, for the kind introduction, and a special welcome to everyone who's joined, and especially to my fellow panelists. So I will quickly introduce Dr. Gandhi and Dr. Benson will each be joining as well. Dr. Bender Ignacio, you just heard from. We will be joined further by, as you can see, by a luminary panel here of first Peter Chin Hong from UCSF, who will also be leading the inpatient panel. We are joined by Kara Chu from UCLA, a member of the Division of Infectious Diseases, by Gadi Haidar from UPMC, who's also in infectious diseases. We have a special person who is an honorary infectious disease person who in fact did an ID year, but is an OB-GYN, Laura Riley, who's head of the department at Weill Cornell. And I'm not sure if I see Teresa here yet, but Teresa may be joining later one of the panels. But for now, we're really, I think I got everyone there. So we'll just, and these are my disclosures. I believe everyone else's disclosures may be found in other materials. These are the objectives that we will at least be able to list the recommended outpatient options for recent COVID-19 infection in the outpatient setting and translate some recent data regarding the outpatient world into real life scenarios. To that end, I'll begin with a discussion about who qualifies as high risk. And this is a 22-year-old woman who is pregnant at 18 weeks, who's presenting in the prenatal setting. She is unvaccinated against COVID-19 and is also skeptical even about the influenza vaccine, which is typically recommended. She has a pre-gravid body mass index of 35. And past medical history of migraines, and she does have asthma, which can bother her at times, and has some inhalers. She is a previous smoker, has quit for her pregnancy. And so just a question about who qualifies as high risk. There's a number of conditions that do qualify people at potentially high risk for poor outcomes due to COVID-19. I'll begin with a question to Dr. Chu. What are the features here that worry you about outcomes, and what are potentially protective factors? And would you consider this patient high risk enough to consider treatment?
Yes, thanks for the question. So I think she has multiple risk factors for progression to severe COVID. She's pregnant, which is a major risk factor for severe disease. Also unvaccinated, of course, and then has a high BMI. And her asthma history as well is a risk factor. Her age is probably protective, but I think her multiple risk factors otherwise really outweigh that, and she should be considered for treatment. Or
so Yes, and so right now it's hypothetical. She's currently unvaccinated. And so I imagine that many OBs may encounter this. And this is just a CDC graphic with some highlights of what risks there are in pregnancy. Dr. Riley, I wondered if you could take us through how you translate some of these statistics and risks to patients when you're counseling them.
Yeah, happy to. So I think, the conversation for most patients, most pregnant patients, or those considering pregnancy, is really thinking about the risk of the vaccine versus the risk of the disease. And I think that we have great data now showing that the risk of the disease could be quite severe with ICU admission, increased risk of death. I think we've also realized that there are fetal complications, which sometimes patients forget about. But things like stillbirth and prematurity are also, significant risks for women who get COVID in the course of pregnancy. And then obviously the other one, not so obvious, but we have seen over the course of the pandemic is increased risk of preeclampsia, which is another, sort of pregnancy specific complication. So I think it's clear that COVID's bad in pregnancy, how you slice it. And then what we have also learned over the course of time is that the vaccine itself, though, appears to be quite safe. And now we can say to women very clearly, we've got a lot of data to show you that the vaccine doesn't increase the risk for miscarriage, which is always a concern. It doesn't increase the risk for birth defects, which is another huge concern. And we can actually prove it now because we actually have the data. I think we were a little bit behind the 8 ball when the vaccine first came out because pregnant women part of the clinical trials. But now we have real world data to back all of that up. So on balance, we say that it's much better to be vaccinated and boosted if that's what's, if the timing occurs during pregnancy. So we encourage people to either get the primary series during pregnancy or the booster if that's what they're, if that's the appropriate timing.
Thanks, Laura. And so, I am seeing a question in the chat as well that how do we discuss the risks benefits of vaccine when at this point in the pandemic, patients are experiencing vaccine hesitancy and I encounter patients who receive their primary series but are also reluctant against boosters. And I just wanted to show this graph of booster dosing by country, recently accessed on this Our World in Data site. And you can see how the United States, while we have them available since the beginning, we had vaccine early on, as well as recommendations for boosting, how we're beginning to lag behind other countries. And then not only within our country, but that there are regional differences regarding vaccine hesitancy. So, I noticed our panel is mostly from the either California or Washington or the East Coast. But Dr. Haydar, you practice more in the middle of the country in Pittsburgh. And so I was curious, can you describe some of your experiences with vaccine hesitant patients?
Yeah, thanks for that. I will say the experience has definitely changed over the past two and a half years, and my experience is a little skewed because the patients that I see in this council for vaccines are all immunodeficient. So I only see, pre-post SOT, BMT, CAR-T, and things like that. So the bulk of these individuals sort of know that they're immunocompromised and actually may come to me. They have come to me with questions about updated CDC recommendations for vaccines before I even know about them, which is a bit funny. But yes, there are those who in the early stages of the pandemic were vaccine hesitant. And one piece of advice that a palliative care physician told me while approaching these people is to just approach it with curiosity, and not the sense that I'm there to convince you or to argue with you, but more, why are you feeling this way? For some of them, I feel like I was able to convince them. And for others, and especially now, some individuals have just decided that they're not going to get vaccinated. And And I just don't think it's possible to convince them. One thing I found helpful was very early on, we had conducted a study looking at immune responses in immunodeficient people, and actually a participant in that study reached out to me asking me to speak in her patient advocacy group for patients with heme cancers, because she knew a lot of heme cancer patients who were hesitant. And so I gave them this whole talk and this whole thing, and I think a lot of them changed their minds after it. But I unfortunately don't have sort of this magic bullet to solve these issues.
Still, we appreciate you fighting the good fight here, but in some ways that language is very important. You said to be curious, and I'm just reminded of this show that many of you may have watched, Ted Lasso, where he says, be curious, not judgmental, and it's a philosophy that serves us well in many arenas. So before we move on to this next question, this next slide, I wanted to ask, is Teresa on yet, or are we still awaiting her?
I am here.
Oh, wonderful. Teresa Evering is from Cornell, and you'll hear from her later regarding post-COVID. What can we say right now about if people ask about vaccines and whether they would prevent post-acute sequela of COVID?
Yeah, I think it's a really good question, and questions that we expect our patients to ask. I think there are two ways to think about this. The first sounds relatively simple. The best way to prevent long COVID is to prevent COVID-19 illness in general. So that's the first way to think about vaccines. In addition to social distancing when appropriate, the appropriate use of PPE, it's all part of a pattern of behaviors that can help us to prevent COVID-19 illness. I will discuss in my talk some emerging data that does show decreased risk of long COVID complications, depending on what the complication is looking at, particularly using large electronic health records data that does show that there may be some protection against long COVID in individuals who are previously vaccinated, and that those who have breakthrough infection with long COVID resulting have decreased risk of events when compared to individuals who are not vaccinated. So there is some emerging data looking at that is positive. What's less clear is whether or not in individuals who do go on to get PASC or long COVID, despite being vaccinated, if there is significant difference in symptoms, for example, from long COVID. There is less data in that realm, but there is a growing amount of data that supports the use of vaccines for at least the mitigation of long COVID.
Well, thank you. That's a wonderful answer, and we look very much forward to the talk later. Such an important topic. So what I'm showing on the screen now is a common question coming up really as of summer 2022. So we're hearing so much about novel variants, escaping immunity, BA.4/5, et cetera. And so they're like, well, you know, should I really get boosted at this stage? So what I'm showing is the protective effect of the fourth dose for hospitalizations and severe COVID-19 for the 4-dose group compared to a control group that had fewer doses in Israel in very high-risk patients. So this helped us understand things early on in the Omicron epidemic. But now we're facing vaccines, and now we have this interesting dilemma as to whether to wait for Omicron-specific vaccines. So let's say I'll just present myself. I'm a 49-year-old who's following the rules and has 3 mRNA doses so far, and I'll turn 50 shortly. Should I receive a vaccine on my 50th birthday, or should I await an Omicron-specific vaccine? I'll ask that of Rachel.
That's a great question, Arthur. I think I've been getting that question a lot. I think, again, it's to me, it's always about shared decision making. And, you know, if your 50th birthday, I mean, obviously there's nothing magical about that exact date other than that's the eligibility criteria. But if it's getting close to October when we're projected to have a variant specific that bivalent booster, then potentially it's worth waiting. But if one maybe had a little different scenario in which one had a number of comorbidities, metabolic concerns, or immunologic risk, then it might be more prudent to get that fourth dose right now. So again, I think it's always about shared decision making. A lot of people have asked, is it worth getting a booster, as you said, even with sort of the immune evasion of BA.4/5? And one of the important things, again, I'll use the sort of exercise analogies for the immune system, is that a booster isn't really like getting the same vaccine over and over again, because even if the vaccine is the same vaccine, your immune system is different. Your immune responses have evolved since the first series. And especially in someone who's already had, let's say, an Omicron infection, or even a prior variant of infection, your immune system has been exercised in different ways since then. So you can go to the gym and work on your biceps, but your bicep workout will be different than had you done it 6 months ago, because you've been continually doing biceps since then. So I think the more sort of ways that you have to challenge your immune system, it's like going to the gym and doing a variety of different workouts. Even if it's not exactly the same variant as what's circulating right now, it's still cross-training.
And I'll just follow that up. Like, how should we consider when people state they had Omicron recently, and that should kind of count as their booster? So Rachel, just briefly, do you that concept of hybrid immunity? What are your thoughts on discussing that with patients?
I mean, we don't know entirely the duration of protection from a single variant, but it seems like it's at least a month, likely 3 months, and we don't know what will emerge. I think it's probably safe to wait, again, at least 1 to 3 months after having a most recent infection to get boosted. If one is already vaccinated, I think, I would be much more strong about getting the primary series if one had only had, for example, a single infection and not yet vaccinated. But again, it's, I think, about the number of challenges and the variety of challenges. One doesn't go to the gym only once, one goes back to the gym over and over to get in the shape that they want to be in.
Great. I think if I were a patient, I would very much enjoy having shared decision-making with you. You're very thoughtful and clear about these things. So we'll return to that topic later. So let's return to the case. So this, perhaps you could guess that the unvaccinated woman who's also pregnant a few weeks later presents with 4 days of congestion, body aches, loss of taste and smell. Multiple other family members are ill. There's no change in fetal movement reported, and she is positive via a home antigen test. So I think testing, we just have a pretty brief discussion about this in this series, but could be an entire panel about how to test. So first, I wanted to ask Dr. Chin-Hong or Peter about, should we confirm these diagnoses with PCR before considering for treatment? How do we think about antigen testing and prior probability? And I'll also ask you about whether to test for other viral infections.
Yes, thanks, Arthur. So it all depends on what's circulating in the community as to the performance of the test. So right now, with more than 100,000 cases in the US, pretty much in most states, increasing up to 1 million in reality, because again, most people are doing home testing. The chances are pretty high that if you have a positive antigen test at home, that it's a true positive. So the idea is that most people are actually having false negatives rather than false positives at this point, and it's very common for people to have maybe 3 days, sometimes even more of false negative tests in the absence of symptoms, in the presence of symptoms, and that's really because of the way the antigen versus the PCR works. It's said that you need more than 100,000 viral particles to make an antigen test positive, whereas you need just a few to turn a PCR positive. So basically, the approach is right now, when you have a positive, it's real. If you're lucky to even have that positive early on, when you are exiting isolation and you get to that, you don't use a PCR, it's too sensitive, and an antigen is better for transmissibility. In terms of co-infections, it all depends on the season. Right now, we've had a protracted influenza season. So in some places, they're still seeing stragglers. And, I think the limitation is we don't have a lot of at-home influenza testing, which would be great. And I think that's the second most important test because it's actionable. You can give therapies around it. In the hospitalized setting, I think we test for a wider variety of agents. Of course, the third most important virus in the season, generally winter, although it's been modified because of COVID, is RSV. And again, it depends on the host you're thinking of. So COVID, number 1, 2, and 3, maybe influenza, depending on the season, and RSV, again, depending on the season and the person. Immunocompromised children definitely want to know if you're RSV positive.
Thanks. I wanted to move on quickly, but I just wanted to note that this patient is presenting or calling you at 4 days into the illness. And so there can be wide variability as well as to when they call you. But fortunately, this happens to be within a 5-day window because you can potentially, in this case, confirm by PCR. I'll mention a couple medications that she's on, including inhaled fluticasone and salmeterol. As a reminder, she also has a high BMI. And so, as mentioned earlier, she does qualify as a high-risk patient for potentially treatment. And what would be your preferred treatment option? And think about it now in the Omicron era and that she's day 4. So would it be supportive care? Would it be molnupiravir? Would it be a monoclonal antibody that's active against the current circulating variant? Nirmatrelvir ritonavir, remdesivir, or azithromycin? And if I can ask my fellow panelists what they would choose in our sort of panelist chat, that would be helpful. We'll give it a minute, and I can hopefully be prompted when we have enough responses. I think I'll want to ask while we're waiting, Laura, Dr. Riley, this patient called us a little bit late. I think we've been reminding patients to try to contact us in a timely manner so we can apply therapies. Is that pretty routine in communication to pregnant patients these days?
I'm afraid it's probably not routine enough. I certainly try and, remind all of my patients. It's interesting. I was mentioning to someone the other day, another one of my partners, I said, why aren't patients calling us and telling us they have COVID so that we can do something about it? And she astutely said, because they don't want to be told that they can't come in for their ultrasound or they can't come in for their appointment. So there's a little of the, I don't want you to know that I have COVID because I know I'm going to be, kept out of the hospital. So I hadn't really actually even thought of that, but, in retrospect, is probably of those people. But for those women who do call, we then have, as others have said, a full conversation about the risks and benefits of using medication. And I would have chosen Paxlovid for someone like this. Because it is readily available and because there is really good data on the safety of ritonavir in pregnancy. And I talked to them about, 20-year use with HIV. Now we do have some experience with it as well. And there's a little bit of pregnancy data, which is not showing anything of concern. So that would have been my first choice. I think monoclonal antibodies is another option, but for most obstetrical services, it's really hard to sort of just get access to it. And just the machinations around, can it be given on the labor floor? How many weeks is she? Do you have to monitor? Because now, it becomes this big thing. So I think for that reason as well, I would Paxlovid, which is readily available.
Great. I wonder if a panelist has a taker for potentially defending supportive care, but I guess that argument would be that this patient is young and that in the Omicron era, it does seem to result in fewer hospitalizations. But nonetheless, I personally would be worried about her unvaccinated status, and that could we have a reprise of the sicker pregnant patients that we saw early on in the pandemic. Azithromycin, we had 0 takers in the police, and that's nice to hear. It's tempting to give azithromycin for a viral illness. I know that tempts a lot of PCPs, but we actually have data regarding azithromycin and acute COVID-19 that it was very much neutral in randomized trials. There's one answer here that I think none of the panelists would give, which is molnupiravir, due to its concerns, and we'll return to that a little bit later in the talk. But then it's I wanted to ask Dr. Haidar, who answered, and whatever you can get fastest, and so I think that's kind of one of the things that nirmatrelvir ritonavir is something that is at least in the United States now fairly readily available compared to the logistical issues that you just heard about regarding the others. And it seems like the other panelists are also there, but we'll have an opportunity to delve a little deeper into this case. And so this is just a reminder about some materials regarding the Society of Maternal Fetal Medicine, which there are also materials on the IAS-USA Learning Network regarding pregnant patients, as well as at the NIH website. And so just to remind those of us who don't routinely advise about pregnant patients that there are materials to look at. And so both in the chat as well as amongst the panelists, there were some things brought up regarding the inhaled medications that the patient's on. And so I wanted to ask Dr. Gandhi about this, and I think this was a bit addressed in the Q&A earlier. What are ways we can think about making sure that we avoid drug interactions, and how would you think about the inhalers that this patient's on, both fluticasone or inhaled corticosteroid, as well as salmeterol, I think. So.
These are great questions, and most of us are HIV clinicians, and we've been taught appropriately that fluticasone is problematic with ritonavir, because ritonavir raises the levels of fluticasone, and that can result either in iatrogenic Cushing's as the effect wears off, or glucocorticoid excess. The important point to remember is obviously our patients getting ritonavir or also cobicistat are getting it for months or a lifetime essentially. And that effect on fluticasone is most prominent in people who are on long durations of ritonavir, long durations of cobicistat. So for very short durations, 5 days of nirmatrelvir ritonavir that this pregnant individual would get, I think it is fine to co-administer with fluticasone. Sometimes we will change the steroid inhaler in people with HIV who are getting pharmacologic boosters, but I don't think that's necessary for the fluticasone. And if you look at the Liverpool site, which Dr. Kim has up right now, there's a comment about this for fluticasone with a kind of a green color, meaning okay to give fluticasone. Salmeterol, though, that same interaction gets a red from Liverpool. So there is enough of an interaction between nirmatrelvir ritonavir with salmeterol that if you are able to switch her to an alternative beta-2 agonist like formoterol, I might talk to the patient's asthma clinician to make sure that's okay, then that would be, a better alternative for the beta-2 agonist. So yeah, that would be my approach.
Thanks. And in fact, I just advised my mother-in-law 3 days ago, who was prescribed Paxlovid, and she is on salmeterol, and did not, the doctor did not mention that, nor holding her statin for 8 days. So, so it shows you that it's important to check this, because even some meds that may seem like they're so routine, I was a little surprised that they weren't checked, and I was able to give that advice. But another recent development is the recent update to facilitate direct pharmacist dispensing. And so, Dr. Benson, I wanted to ask you about your thoughts about the pros and cons of that new development.
Well, I certainly think the reason for adding pharmacists as prescribers was aimed at easier access to Paxlovid and getting the message out in a broader population than seemed to be accessing the drug. So I think the intention there and adding pharmacists as prescribers is really one of the big pros would be greater access. And certainly in a case like this, for example, where you're already 4 days into symptoms, earlier initiation would be something that would be a pro of having pharmacists prescribe rather than having her attempt to contact a physician or see someone in a clinic and then get a prescription. Some of the cons, I think, about having pharmacists prescribing is that sometimes, even though the EUA amendment suggests that pharmacists not prescribe it if they don't have complete information about underlying conditions and concomitant medications, that's not always the case when you're dealing with interaction in a pharmacy with a pharmacist that you don't know. And so there is the potential that incomplete information and about concomitant medications, just like we've been discussing, might be one of the cons. And then obviously the communication with the treating physician, that pharmacist is, I believe, should be obligated to contact the physician who's providing care for those patients to let them know that they've prescribed that medication so that there is communication with the treating physician. And then obviously pharmacists don't have the same capacity to adequately monitor patients after they've started the medication. So again, communication with the treating physician is going to be an important component to pharmacist prescription.
Yes, and we continue to move into new eras of treatment, and so we can see the pros and cons of such approaches. And in the end, timely treatment seems important, but we'll get to some of the pros and cons later of what can happen. So here is let's say this we just changed the case up a little bit, and the patient were actually vaccinated and boosted, so a different scenario. Would you then treat with antivirals for this young woman in the Omicron era? I thought I'd turn to Dr. Chu, Kara. Your thoughts on the treating technically patients who are high risk but are vaccinated, who are not represented, importantly, in the EPIC-HR trial.
Right. So certainly vaccinated and boosted, her risk of severe COVID is significantly lower. She does still have high risk factors, the pregnancy and her BMI and the asthma, and so her risk is higher than someone without those comorbidities. While these patients vaccinated with comorbidities and also pregnant were not represented in EPIC-HR, they were included, though not the pregnant participants, in EPIC-SR, which was Pfizer's standard risk study. And there was not a statistically significant reduction in risk for hospitalization or death, but I think a moderately large numerical reduction in hospitalizations or deaths, or the combination, and so close to 60%. So I think there's still potential benefit, and that's where the shared decision making comes in here. And I would probably favor treating, certainly offering treatment, and really strongly considering treatment. Thanks.
So in the interest of time, I just thought I'd flash up some of the top line results that were reported via press release, and we're anxiously awaiting kind of more details regarding what's behind these data, which importantly, these are presented by the company, and so we look forward to both peer review as well as a dissection of these data. But again, it did not meet the primary endpoint, as just mentioned, but there are some trends of interest. And again, these are the individuals who are not high risk as defined by the original high risk trial. So either they would have a condition but are vaccinated, so they have some protection, or they are unvaccinated but don't have any characteristics. I wonder how many of those are actually represented in this trial. But we very much look forward to this. Either way, the number needed to treat would be higher to prevent hospitalization, I think, in these lower risk patients. So just to close out the case a little bit, this patient declines the offer, afraid of effects on the baby and the developing fetus. And she does describe over the next few days on check-ins a worsening dyspnea into her, day 8 to 10, let's say, but her oximetry levels are reasonable. She's advised to take a cocktail from somewhere she found online of ivermectin, prednisone, and azithromycin. And so first, what are considerations regarding dyspnea and home oxygen measurements, particularly in pregnancy? I thought I'd ask that of Dr. Riley.
Yeah, so before we actually go there, Rachel put a really good question, I think, in the chat that the reason that I would have sort of persisted on the Paxlovid conversation, recognizing the patient can always refuse, but I probably still would have pushed forward because I think there's other pregnancy risks that we get concerned about, things like preterm birth. We don't know that necessarily, that risk is any lower now with the newer variants than it was, earlier in the pandemic. And certainly people who, have a fair amount of inflammation and fever, they are at increased risk for preterm birth. So I probably would have presented that data to her as well as one of the reasons. So, so that's just from the last question. And in terms of dyspnea, I think, the one concern is that sometimes people are, will say things like, oh, or O2 sats like 93, 94, big deal. It's, mom is fine at 93, 94, but baby may not be fine at 93, 94. I think in this woman with a viable pregnancy, I think we do two things. One is we would have suggested that she come in for any shortness of breath, which can be tricky because pregnant women, as the uterus gets bigger, will get more short of breath, but usually with exertion. So if she's short of breath, just, chatting with me on the phone, that's a problem. But when we bring them in to check their O2 sats, we do get them up and walking around as well, just to make sure that we're not missing something that is happening. And then that puts her in a whole new basket of concern.
Thanks. That idea of closely watching patients who are at high risk that you're worried about, and making sure they're checking in and bringing them in when necessary, especially when it seems a little complicated. A woman with asthma, as you said, I mean, there's many reasons to keep a close eye on this, and also as we just heard, a bit more thinking about treatment for reasons, even though she didn't seem that sick initially. So I wanted to turn to this unproven treatment recommendation issue. I have to say, one of the things that COVID-19 has revealed is how difficult it is not only for science to advance, but also to communicate about that science, which is constantly changing. And so I'll return to Dr. Haidar, if you've encountered these scenarios and sort of what are your thoughts regarding, again, counseling patients who may bring you some of these alternative therapies.
Yeah, and it's always difficult. Similarly to the issue of vaccine hesitancy, there was a time where I think ivermectin was very in vogue in the media and was a bit controversial in ID circles. And at the time, it made it a bit difficult to have the ivermectin discussions because we weren't sure. If we didn't think that it might work, we just weren't sure because the data weren't there. Now the data are there. And so, I mean, my approach is to just say, yes, but we now know for a fact that ivermectin really doesn't do anything for COVID-19. And actually, some people who take a lot of high doses on their own have come to the ER with toxicities and things like that, and do your best to convince and to not condone. And similarly with azithromycin, I feel like fervor among patients who may not be aware of the right therapies for drugs like azithromycin and hydroxychloroquine has waned over time. I feel like there's definitely been a shift compared to the discussions we were having a year and a half or 2 years ago. And for the prednisone, my approach is to just highlight to these patients that, well, you're not on supplemental oxygen, there's really no benefit here, and I worry about immunosuppressing you further. I do think that there is a lot of outreach that can and should be done to providers in the community to try to avoid prescribing drugs that are ineffective or are harmful, especially since we have a lot of drugs that work. Our system does that. There's a lot of emails that go out telling people what to do and what not to do and things like that. But I think that at times it's difficult to change behaviors.
Yes, and I'm sure many of us could tell stories from the unproven treatments or yet to be proven treatments from early on in the HIV epidemic that were going around. And so, there are so many parallels. Well, just to kind of finish out the last theme of the flagship case that I wanted to present, just wanted to note that there is a literature that predated COVID, but has been really brought out with COVID, that many of the oximeters that are deployed in practice were calibrated not necessarily rigorously on darker skinned individuals. And so this is just showing some splay of different race and ethnicities, and that there's a greater likelihood of underreading or missing hypoxemia in certain subgroups. And then also just wanted to point out the disparities in accessing these therapies, and this is the CDC report, but our own internal data within our system would definitely say this, that from a suburban that has, that immediate access to their doctor, how quickly they could get these therapies as opposed to other communities that will have less access. And Peter, I remember having this discussion with you when we did this ID week session together. What are your thoughts regarding disparities at this stage in the epidemic?
I mean, I think they're huge and they continue. And I think I've been struck by data showing that disparities in general, when you look at hospitalizations and deaths, they occurred not just early in the pandemic, but they continue during Omicron. There's lots of data to show that. And when you dive deeper and you look at some of the current therapies that we have available for outpatients, like you've been talking about Paxlovid and you're showing here, there's now ample data, not only in the MMWR, but by the Kaiser Family Foundation, showing that, sure, most counties have access to facilities that can dispense Paxlovid and other oral therapies, but the number of prescribers is very different from county to county, and they go along the lines of race and ethnicity and socioeconomic status. The federal government doesn't provide data on who actually gets Paxlovid, but we make an assumption, and based on my own personal experience too, that there are many people in vulnerable communities who are not getting access to Paxlovid, not only because they don't know about it, but because the providers in that area have misinformation about Paxlovid, particularly around rebound, and therefore are not prescribing it. And so the idea that pharmacists can do it will hopefully make it better. One-stop shopping with drive-thrus may hopefully make it better, and not only for these communities, but for rural communities as well.
Thanks. This has clearly revealed something that existed pre-pandemic and just continues to be a stark reminder of how our health system delivers care. So I think, relevant to some of the chatter in the chat, I think, as well as a very timely topic, I'll present an 81-year-old male government official who attended a college reunion and then a few days later has tested positive for COVID-19 via routine antigen tested. This gentleman is fully vaccinated, boosted twice, developing mild symptoms just on his first day. And so he received 5 days of nirmatrelvir ritonavir, and with clinical improvement, he then is regularly tested and is negative for 3 days. But day 4, the antigen test reverts to positive. And then shortly after, this gentleman developed symptoms that were much worse than the first episode, but he is not yet hypoxemic. And so this is a case of rebound that is associated with Paxlovid use. And so I hope people may recognize who this is in the chat. You can take your guesses, but I wanted to ask Dr. Evering in terms of how you're currently counseling. I'm sure you've fielded a few questions by now regarding rebound as of July 2022, as we await more data.
Yeah, so it's an important question. It's important to understand what we believe about the rates of rebound currently in the clinical trials that led to the approvals of Paxlovid. It was about 2%. And in subsequent trials, it's been anywhere from between 1% and 2% approximately, although anecdotally, we hear a lot about it. It's important to understand what the current recommendations are in terms of guidelines. And currently, the guidelines do not recommend any role for retreatment at this time. Now, what happens in the community, what's happened in this case and a number of other high-profile cases can be very different. But currently, the recommendations are not to retreat. And typically that's because rebound cases in general tend to not result in hospitalization or increased morbidity. They tend to be milder. And there is also the question of whether or not this is in fact rebound or recrudescence of the initial COVID-19 illness, which can occur. So it's a difficult conversation to have with participants or patients. And thus far, I have not personally retreated anyone because that hasn't been, I haven't seen someone that's had worse symptoms during their rebound case, but I understand that it's a difficult conversation to have and it can cause a lot of anxiety with patients who have taken what they believe to be the best medication for their mild to moderate COVID-19.
Dr. Benson, I wanted to follow up regarding your thoughts regarding rebound and potential retreatment and what you'd like to share about it.
In general, I agree with the comments that have already been made, but I have a little bit of a different take on it. And one of those has to do with the fact that I don't think the original trial done with Paxlovid adequately addresses this question. I don't think the follow-up or the patient population that might be at risk for rebound were appropriately represented in the clinical trials. So I think, in fact, we don't really have an answer for whether longer duration of treatment might be appropriate in some populations because that wasn't part of the trial. The trial also enrolled people that didn't include a large proportion of individuals who fit the case that you're presenting. So for me, I think there are a number of unanswered questions about rebound in the context of COVID. And if I can digress from our own clinical population, we actually have seen a much higher rate of rebound than the 2% that is described by Pfizer in their clinical trials. So what are the factors that might favor rebound or increase the risk of rebound? I think it would be pretty easy to guess that the recency of the vaccination and boosting might be a factor. Older age in this particular individual, 81, is quite a bit older than the population studied in the Paxlovid trials. Underlying immunosuppression or other comorbidities that affect the immunological reserve, like what we heard from the talk about HIV, may impair the ability to ramp up an anamnestic response. So I can see certain situations where retreatment might be an appropriate approach. Whether we'll ever have answers to those questions in an appropriately conducted clinical trial remains an issue for all of us trying to deal with these difficult discussions. There also could be a theoretical benefit to retreatment of a rebound because I can tell you from personal experience, the rebound in symptoms are accompanied by a rebound in viral shedding and subsequent duration of quarantine and potential transmission in a household or in some other closed setting when you have a rebound episode continues to be a problem, despite mask wearing and the other PPE that people are recommending. So I think there's a lot of different things that go into a decision about whether you retreat. And I don't think that obviously the FDA can't go beyond what data they were presented, and their recommendation is based on the data that they were presented, but they weren't presented data in some of these other exceptional circumstances where you might consider retreating during a rebound episode. So I think in summary, I think we need to be a bit more flexible with our recommendations than the FDA is allowed, and maybe take into consideration some of these other factors.
Yeah, so clearly there's a lot to be determined here, as you're saying, and whether we'll have these data sources is kind of an interesting question, because as you mentioned, will we have to derive it from data sources that don't quite get at the exact answer that we're looking for and that are strong enough to change FDA in particular. I did want to highlight this case series that was recently published in Clinical Infectious Diseases regarding 7 individuals who experienced this rebound. And so, as many of us have already heard or experienced or managed these rebounds, I mean, this is just kind of classic in terms of when it occurs a few days after the end of the Paxlovid treatment. And then there are implications for isolation, as you just heard from Dr. Benson, regarding the shedding that the viral titers at relapse can be quite high. And that these individuals, 3 out of 7 had positive viral cultures, which may be a surrogate for contagiousness, not sure, but it took a while for those individuals to revert back to negative. And so, I do think that rebound has resulted in a bit of, reluctance amongst providers and even amongst patients who may not want to experience, up to 2 to 3 weeks of isolation. Then again, we really don't know if it's associated with Paxlovid even. Importantly, none of the reports so far have shown development of viral resistance. And I think it's really an open question as to whether 5 days is really enough for most people or not. And so there's definitely more to come, and sounds like a future topic for perhaps an IAS-USA webinar to delve deeper. So I don't know if any of the other panelists want to share thoughts regarding rebound and some of the comments in the chat as to whether or not one should perhaps wait for further symptoms to develop before initiating Paxlovid. This concept of perhaps allowing some time for the amnestic response to develop. These are all such open questions. I'm
happy to make a brief comment. I agree with Dr. Benson that in these cases of rebound, it is a case-by-case determination, and the factors she outlined, age, frailty, immunocompromised state, would influence my thinking. But like Dr. Evering, the bulk of the patients I've heard about or consulted about tend to have milder symptoms the second time around, and in most instances I have not retreated because either the person has been recently vaccinated, has mild symptoms, and is not particularly frail. So I think we do have to have some flexibility, but I would say the majority of patients I don't end up treating who have rebound. One attendee asked whether this has been seen with other drugs other than nirmatrelvir, ritonavir, or Paxlovid. Or could it happen even in the absence of any drug therapy at all? We'll remember back to 2020, back before we had any effective drugs, there was a biphasic nature to COVID-19. There is a preprint that's circulating now that looks at what they say is rebound with molnupiravir versus nirmatrelvir, ritonavir to our 2 oral therapies. And the headline from that particular preprint is that the rates of rebound were the same or similar between molnupiravir and nirmatrelvir, ritonavir. If you delve down into the nitty-gritty though of that preprint, it's a administrative database with a large number of individuals, but they really can't distinguish lingering symptoms, which Dr. Evering is going to talk about at the end of the symposium, from rebound. That is, they don't have granular data as to whether a person with either nirmatrelvir ritonavir or molnupiravir gets better and then has recrudescence, or whether they just have lingering symptoms. So I don't think it's a very definitive preprint in this case, and we'll see where it goes in peer review. So I think that we will see cases of rebound with other drugs. As to whether it's more or less frequent with nirmatrelvir ritonavir, I don't think we know. I think there's a lot we don't know. Lastly, I would not personally delay treatment with nirmatrelvir ritonavir if people otherwise meet the criteria for receiving the drug. That is to wait for the endogenous immune system to kind of kick into gear. I think all antivirals tend to work best if you give them early, and I don't think the evidence that rebound is somehow related to a lack of an endogenous immune response is firm enough for me to advise myself or others to wait, even though there's been a lot of discussion on Twitter about that.
Thanks, Raj. And the question in the chat, I mean, I do want to clarify that based on this case series and whatnot, that I would recommend isolation for symptomatic rebound at this time. The antigen test, perhaps as a surrogate. There was a high concordance in this study from Mass General regarding that, and at least one of the series about rebound suggested that there were transmissions in a couple of cases during the rebound period. In the interest of time, I will skip this brief comment about nirmatrelvir resistance, other than to say thus far we've not seen it after Paxlovid. Instead, for the last few minutes, I wanted to highlight some issues that will segue into the inpatient side. But a 65-year-old gentleman who underwent a kidney transplantation, he's well vaccinated and in fact received tixagevimab, silgavimab, the Evusheld product in January. He developed symptoms consistent with COVID-19 and is positive, and we'll take that as a positive, as you heard earlier from Dr. Chinhong, and he's maintained on this mycophenolate, prednisone, and he's on belatacept. And he's also on atorvastatin and allopurinol. He's statting well on his home oximeter. And just thinking about this patient and how high risk they are, Dr. Haidar, and you and others on this call as well take care of immunocompromised patients. How do you view this person's risk, perhaps in contrast to the first case?
Yeah, this person is extremely high risk, and there's a lot of variables going against them. They're 65, they've had an SOT, so an organ transplant. They're also on triple immunosuppressive drugs, including MMF or mycophenolate, which is known to be independently associated with poor, at least humoral responses to COVID-19 vaccines. They're also on belatacept, which is an injectable immunosuppressive drug that targets signal 2, and this one has also been associated with bad vaccine responses and also bad outcomes after SOT. And you can maybe also throw in dyslipidemia in there as a risk factor. So this person is very, very high risk.
And so I just wanted to highlight this slide, which is available on the IAS-USA Real-Time Learning Network, which represents that 4-dimensional risk strata that we're constantly doing for patients who are presenting with COVID, and just thinking through their degrees on each of these axes. And if they're more in the red zone, if they have 2 or 3 in the red zone to push towards treatment, and then if they're more in the blue zone, they either don't qualify or whatnot. But this patient is really pinging on a number of levels. So I just thought this was a nice way to highlight, as well as even amongst the different types of suppression, that there are those who are more mildly, more moderately, and severely immunocompromised. And so at varying times in the pandemic, we were rationing. Just briefly, Peter, what was the UCSF experience? Did you have to triage at your institution when supplies of, say, sotrovimab or Paxlovid were rare?
We hemmed and hawed a lot about whether or not we should prioritize or make these tiers, and there have been different systems all over the country, like University of Toronto, etc. But we decided at the end of the day, being California, that we couldn't really do that given the data that we had. So it essentially became a first come, first serve within a general tier of immunocompromised. And we basically didn't really have to end up doing anything because, as you know, the uptake of these monoclonal antibodies, even long acting, wasn't quite as robust as we had anticipated. So that was basically what it came down to. In terms of Paxlovid and other therapies, again, there were maybe a couple of pharmacies in the beginning that were giving them out. So we prioritized patients to get these. It was very, very difficult to treat patients admitted with a diagnosis of COVID, as you know, with Paxlovid. So if you came in with a broken foot, but happen to have COVID, we can give you, and the diagnosis with broken foot, we can give you Paxlovid, but not, otherwise in those early days. So lots of barriers, but hopefully getting a lot better.
And so, at this point, we do have choices. So we'll just ask at the end here, the audience in terms of what would be the preferred treatment option for such an individual. And I know many in the audience may not be taking care of patients who have transplants, but just wanted to give you an opportunity to exercise the audience response and discuss what you might want to do. And I've added, instead of azithromycin, the choices are similar otherwise. Instead of azithromycin, I added convalescent plasma just to see what people think. So I was advised to fill time. If just quickly about molnupiravir, when do we use molnupiravir these days? Dr. Benson, I was going to ask you this. I guess nobody.
Well, I think that's a very good question. I have not yet had either the need or desire to prescribe molnupiravir. It's generally indicated for treatment in individuals who can't receive other available therapies. And thus far, that hasn't really been the situation in our institution. So we have sort of a hierarchical approach, as I'm sure many institutions do. If it's an outpatient with mild to moderate disease, if they can access Paxlovid, that's our first choice. If they can't access Paxlovid, the second and third choice has to do with bebtelovimab or remdesivir, depending on whether or not we can organize the infusions for 1 day or 3 days. And only in the instance where none of those therapies are available or can't be accessed would our impetus be to organize molnupiravir. I think there are potential pros to molnupiravir. The drug interactions are not an issue. The use in people with underlying renal failure or hepatic disease in this case, kidney transplantation, if there's renal dysfunction, are not an issue. So some of the things that go along with all the difficulties of using Paxlovid are not a problem with molnupiravir. But as we all know, the efficacy of molnupiravir has fallen off substantially from the other available therapies. And so the maximum benefit one could expect in terms of reducing hospitalizations and deaths is substantially lower than with other available therapies. So I think you're in the realm of a discussion with the patient about the best options and what's available. I'd be interested to hear what the other panelists think about molnupiravir and whether you've used it.
Well, I've quickly used it. I believe the first or the second prescriber in our system when we had our supply. And so we were triaging Paxlovid to the higher risk patients, patients who were lower tier who would have logistical issues or were also unable to achieve sotrovimab at that time. And remdesivir was not set up. And so we just ended up using molnupiravir. And we continue to see a few prescriptions in our system. And, I think if you have someone who's awaiting antibody within a 7-day window, but you want to get them started and they do have this drug nearby and they can't take Paxlovid, then those seem to be the situations I can imagine. I just quickly about molnupiravir, this is very reminiscent of ribavirin and sort of its issues regarding genotoxicity, and we would not give it to pregnant patients, for instance. Laura, I'm really reminded about ribavirin and sort of counseling around those issues. So, just bullet points for this group who may not have prescribed ribavirin in terms of how to counsel patients of childbearing potential.
Yeah, I mean, I think that, any drug basically that looks toxic in animals is a drug that we're not even going to think about using in pregnant women over the concerns for congenital malformations. And so, as Dr. Benson said, thankfully for us, there are alternatives. And so we would not have used molnupiravir just based on the animal data. That would be it. It's a full stop no. And the fact that remdesivir and Paxlovid were available made it an easy decision.
And then as a reminder, just to take us through the cases, we're nearing time here, that ritonavir is very problematic with potentially tacrolimus if this patient were on that. However, this patient happens to be on basiliximab. And so, this patient actually received bebtelovimab. I think our transplant providers were just so used to sending all their patients this way is that they immediately did that without realizing that this patient happened to not be on tacrolimus. And so just to note that it is active against the variant and remains active even against BA.4/5. And while we lost sotrovimab, we do have this agent. But we lack like a lot of clinical data, and especially in randomized controlled trial format, that it's really extrapolated based on the other antibody data. There's some real world data suggesting efficacy, but nevertheless, this has resulted in a slight downgrade compared to remdesivir, which is a preferred therapy. And so you can see the rank order here again of Paxlovid being first along with remdesivir. As a reminder, remdesivir through the Pine Tree trial is a 3-day course of an IV infusion. And so while bebtelovimab is alternative, I think many systems have seen that 1 dose is easier to implement than 3 doses. And so that seems to be the main barrier to use of remdesivir. And as a reminder, the efficacy for reducing hospitalization and death, while it looked good in the interim analysis at 50%, the post-interim analysis didn't quite look as good for some reason. And then in the end, we resulted in this 30% reduction for molnupiravir. And then finally, this patient after recovery, I think earlier, Dr. Bender-Ignacio addressed how soon after recovery, perhaps wait a few weeks before receipt of the next due vaccine. And this patient was dosed with tixagevimab in January 2022. And thus, as a reminder to this audience, now the FDA has authorized 6-month repeat dosing of tixagevimab, at this time. And then I think we've been asked to kind of wind down. There are a few other issues that we could talk about, including prolonged illness in immunocompromised hosts. And so this is a gentleman who, after bebtelovimab, the case he did develop multifocal infiltrates. And I think several of these themes will also be taken up in the inpatient session, and so as a preview. So I think at this time, I'd like to sort of close in terms of this section so we can get to the Q&A. But I just wanted to thank our panelists for their wonderful responses and going through the cases, and hopefully some timely advice to the audience to hear this expert crowd give on these very timely issues. So I'd like to close there. These are just some take-home points from those cases, which will be available for download after the session.
Wonderful. Thank you, Dr. Kim. I think we have 5 minutes for questions. I'll try to do a rapid fire lightning round, starting with the question of testing. Are current antigen tests picking up BA4 or 5? I'm going to ask people to comment. I don't know who to ask. Arthur, you want to comment on antigen tests in BA4, BA5?
Yeah, I believe that they are. You know, anecdotally, the latest cases I've heard about, many individuals often have sore throats as predominant symptoms, as well as sort of less loss of taste and smell in the Omicron era. With BA4-5, it seems like there is a return a bit of the taste and smell. There is a lot of off-label use, I should say, of swabbing one's throat if sore throats are predominant. But nonetheless, I do believe it's picking up BA4-5 based on all the anecdotes I have around me, as well as what our lab tells us that it should be remain sensitive for BA4-5.
You made a nice comment, though, about the fact to always retest if you have a compatible clinical syndrome and then have a negative test. I have recent household experience with this phenomenon of early antigen tests being negative, and a couple of days in, the antigen tests turned positive. I don't think it's the BA4 or 5 issues, just the sensitivity of the antigen tests, as Peter said before. A question that I'll direct over to Dr. Ignacio Ignacio, sorry. Data clinical efficacy of tixagevimab, silgevimab, also known as Evusheld, against BA4, BA5. That seems to be an appropriate theme of the day. Do you have any insights into whether that will work against BA4 or 5?
Yeah, so of the two drugs, one takes quite a hit in all of the Omicron variants, and the other one retains, say, a modestly reduced neutralization in the lab. So we don't have really strong clinical data in the Omicron era because most of the studies were done before Omicron. So what we have is there's a really nice national database that the Foundation for the NIH maintains with all of the lab data, and it shows the fold reductions against all of the different variants. So we see, depending on the study and depending on the Omicron subvariant, a reduction somewhere between 3-fold and probably 50-fold or maybe even 100-fold in some cases. But the combination of the two seems to have less of a reduction. And then it's important to note also that in the original studies, the neutralization concentration is in the nanomolar range. And what we can achieve in the blood is in the micromolar range. And so even taking, up to 100-fold reduction, the idea is that it's probably still effective, especially for prevention, because when we're looking at prevention, we're looking at having to neutralize less virus than in someone who already has disease, already has the infection. And then just sort of taking a poll of colleagues who are using this, and for example, in our transplant patients, clinically, we're seeing some breakthrough infections, but tending to be of kind of mild and moderate severity. I don't think that anecdotally, or maybe slightly more than anecdotally, among at least my healthcare system, we haven't seen people who've gotten tixagevimab, silgevimab within the last few months end up hospitalized with a breakthrough infection. Again, I think we're seeing a few sort of mild to moderate cases, and I don't know if others have that experience.
Because of time, we'll just take one last question and then carry forward the rest to the roundtable. Dr. Chu, if getting a fourth booster dose now prohibit someone from getting a booster in the fall, what would you project?
I think that in the fall, it'd be a few months from now, so maybe not. Yeah, we do like to have some space in between boosters to, I think that increases the efficacy of the boosters. And so having a rest period is a good idea, but no, I depending on the timing, it may not preclude another booster.
Great. And I think we're going to do a couple of BA4, BA5 questions and booster questions during the roundtable. So with that, I'm going to give everyone a break. I think some of us will go eat lunch, others will eat breakfast, others might eat dinner. So why don't you take a quick break and we will join for the hospitalized patient segment of the symposium and the post-COVID lecture in the second half. And I want to thank all of the panelists and the moderator for leading a really outstanding discussion today, as well as our first speaker. See you in a bit after the break.